So we are live in 5, 4, 3, 2, 1. We are live now.
Good evening, everyone. We welcome you all to OrthoTV online in Pulse Pharmaceuticals, the makers of Deksel, Bakbone and Kneeflex, to introduce today's speaker and the topics. I hand over the proceedings to Dr. Harsh Chaturvedi.
Thank you so much, Dr. Bijlani, and it's remarkable that time and again you give us an opportunity to present our programs here, where we have eminent speakers sharing their thoughts and their experiences. Very warm welcome to you all, ladies and gentlemen. I'm Dr. Harsh Chaturvedi. I look after medical affairs and clinical research of Pulse Pharmaceuticals, and I have the honor of not only talking about my company and briefly presenting it to you, but also of introducing our guest speakers each time we have a program on OrthoTV. Without much ado, I'll request my colleague, Mr. Upendra, to share my slide deck so that we can get the program rolling. Can I have the first one, please? Go to the presentation mode. So, as I mentioned, we are from Pulse Pharmaceuticals, a company which believes in passion for innovation and compassion for the people. Next one. And ladies and gentlemen, we have two very eminent speakers with us in Dr. John Mukhopadhyay and Dr. Vikas Jain. And I must say that we have never had such a desperate board, to be talking on the subject to us. You will realize why I'm mentioning this as I go on with the introduction of the speakers. Can I have the next one, please? We have Dr. Vikas Jain with us, who is the CEO and founder of Arogyam Orthopaedics at Vapi in Gujarat. He is an orthopedic hand surgeon by profession. At the same time, he is a highly accomplished change leader in healthcare. His passions are healthcare strategy, resource optimization, investment banking, mergers and acquisition. He likes to call himself as an entrepreneur. He is a value creator, and he is an exponent of 3D technology in orthopedics. His current focus, I would say, is on low-cost healthcare and digital healthcare. He's been past president of Gujarat Orthopaedic Association, past president of Rotary International, and a past president and trustee of Indian Medical Association. With these words, I welcome you, Dr. Jain, to this forum. Can I have the next one, please? And we have immense pleasure in having Dr. John Mukhopadhyay, Head Department of Orthopedics and Traumatology from Paras HMRI Hospital at Patna. Dr. Mukhopadhyay is the chairman of Orthopaedic Research and Education Foundation of India. He is the ex-chairman of IOA Trauma Committee, a member editorial board for the new e-journal Patient Safety in Surgery. He is a member of editorial board of the journal Strategies in Trauma and Limb Reconstruction, which is published by Springer Verlag. He is a reviewer for the Indian Journal of Orthopedics, past president, Bihar Orthopedic Association. He has been a faculty at numerous national and international courses and the meetings, and has authored many articles and chapters, both for the state and national journals, as well as in many books. It's a pleasure to be having you here, sir, and it will be great listening to your experience and thoughts on the challenging cases in osteoporosis. Can I have the next one, please? And finally, I would like to introduce my organization, Pulse Pharmaceuticals, which is a patient-centric, innovation-driven, integrated pharmaceutical company with inclusive growth model. We have our R&D, we have our manufacturing facilities. We have been there for the past 25 years across India and the emerging markets. Now we are poised to make forays in European market and the US markets, which are more stringent regulatory-wise. We have a world-class R&D and manufacturing infrastructure spread across the state of Telangana and Uttarakhand. We have a strong leadership team and operational teams across all business functions. We have 7 divisions catering to the various specialties, including orthopedics and neuropsychiatry. We are leading in the space of nanopharmaceuticals and drug delivery research. Our Nanoceutica, which is a part of our R&D, is manned by 70 scientists, and we have been developing various formulations using the limitations, targeting the limitations of the drug delivery systems. We have strong presence in medical nutrition as well, with our sister concern, which is Pulse NutriSciences, which is catering to the nutritional requirements of critically ill patients, patients with cancer, and also something called the medical nutrition therapy for the diabetics. And recently, we have forayed in the immunocell therapeutics by developing CAR-T technologies, which is the stem cells using the recombinant DNA technology. With these words, I thank you for joining us, and I initiate the academic discussion by handing over the session to Dr. Vikas Jain. Dr. Vikas Jain will be speaking on the relevance of FRAX in the current scenario. What we would like to hear from Dr. Jain is how relevant is FRAX score or FRAX tool in today's context, and especially in the Indian context, because of the Deksel not being available everywhere in the country. Looking at the socioeconomic status of the patients and the population, and I would also specifically like to understand from him, is there a need to combine FRAX tool with Deksel to arrive at better conclusions? Furthermore, somewhere I believe during the course of their discussion, Dr. Mukhopadhyay or Dr. Jain will be talking about the newer emerging risk factors, more so about homocysteine and its relevance to osteoporosis, because we do understand it's more about breaking the collagen network rather than deminerating the bone per se. And it has implications far more than the cardiovascular issues that we have been embroiled with, and the central nervous system issues. So I do also osteoporosis somewhere looking at the nutritional issues. I was reading elsewhere that somewhere iron deficiency anemia per se is contributing to the osteoporosis. So with all these things, we have quite a bit to learn from both Dr. Jain and Dr. Mukhopadhyay. And I hope you will have a very enlightening evening. With these words, it is over to you, Dr. Jain.
Thank you so much, Dr. Harsh, and thank you for giving that elaborate introduction. I'm a very simple person with a passion and a purpose in life towards doing some efforts, being an orthopedic surgeon all throughout and continuing to be that, but doing something different for the humanity. And I would request who's going to play my presentation so that we can take it ahead. We'll introduce osteoporosis first. We'll introduce the problem statement. And then we will try to understand what is FRAX. And then we will try to understand what are the challenges that very renowned orthopedic surgeon, Dr. Mukhopadhyay, has in his day-to-day practice in managing the fragility fractures. Friends, my first slide says that I am a longevity expert and I talk on longevity. And that's exactly the reason why I feel that osteoporosis is one of the problem statement that we need to address in our country as well as globally. So here is where I am taking my passion to a purpose, and then I will then take it to the fact that we can make it a profession. So usually it's the profession followed by passion and followed by purpose. But here we are trying to address a very big problem globally as well as in India, and which is osteoporosis. Can I have the next slide? Friend, when we were trained as orthopedic surgeons, we started our journey with repair, rehabilitation, reconstruction, fixations. However, as an orthopedic surgeon, we never believed ourselves to be physicians. But however, the time has come and the world is indicating towards us that we need to start. We are in a change position where we need to address the community about the silent epidemic that osteoporosis is going to be. And this is for the good of the orthopedic surgeons, because they are going to face many challenges in future as we are going to have an increase in the global population as well as the population in India over 60 years of age with really bad bone quality. Next slide, please. Can I have the next slide? Yeah. So if you see, we have to stop at least we do not want fragility fractures at all. What it says is, even if you have a history of having a fragility fracture, you don't want further fragility fractures. Can I have the next slide? So everyone, we find in our day-to-day practice that most of our even well-educated patients are not well aware about the quality of their bone and joints, and they do not know about the way they lose their bone quality as and when the time passes, as and when they age. And there are multiple environmental factors which play a very important role in reducing the bone quality and enhancing your fragility. Hence, in order to have a very good longevity, in order to have your life which is free of diseases, even in your 60s and 70s, you need to understand your bone quality at a very early age, and that sensitization has to come from us as orthopedic surgeons. Next slide, please. So we need to boost our bone health. Can we go ahead to the next slide? Yeah. So how do we define osteoporosis? If you see every word that is specified here, it's a systemic skeletal disorder, and it's characterized by low bone mass, microarchitectural deterioration of the bone tissue, which leads to the fragility of the bone, and it increases our risk to very minimal fractures, to very minimal trauma. Even there is hardly any traumas to be complained about, and yet your bone becomes very papery and it ends up having fractures. Next slide. So if you see osteoporosis, if you go a little historical, in the 1800s, it was a French pathologist, Jean Lobstein, who coined the term osteoporosis, followed by an endocrinologist, an American one, Fuller Albright, who linked osteoporosis to the postmenopausal state. Next slide. This is something very interesting, not very commonly understood and known to many people, all my fellow orthopedic surgeons. Let me tell you, this is an evolutionary aspect of osteoporosis, which I came to know and understand that for us, from the quadruped, when we became bipedal, it was the forces and the stresses over our bone, which enhanced our porosity much more than that it would happen in a quadruped gait. And that is why animals do not get much osteoporotic. It is the humans who become osteoporotic more. This was something more about the evolutionary aspect. Next slide. If you see the problem statement, globally, if you see there are over 200 million people globally who are osteoporotic. Approximately 5 to 6% of males and around 10 to 12% and even more females are affected above 50 years of age, more in postmenopausal women. This is an important stat where you see in a 60-year-old woman has a 44% risk, while a 60-year-old man has a 25% risk of getting a fracture. 1 in 3 and 1 in 5 in men, 1 in 3 in women over 50 years of age have a chance to get an osteoporotic fracture. However, there are multiple other factors like vitamin D deficiency, lack of sunlight exposure, our bad lifestyle, bad diet. All these problems are aggravating. These are external factors which aggravate our problem of bone health optimization. The most important thing is the socio-economic burden that these fragility fractures are having in each country and over into the society. Next slide. So if these are common things, most of us would know that bone health, as far as women are concerned, they are in their perimenopausal stage and postmenopausal, the hormones which play a very important role in maintaining the bone health. Somehow when they reach this stage, they start to lose their bone. They do not realize. It is seen in a very common condition in most of the all socioeconomic classes. It's not that the higher class of the society are more sensitive and they do bother about it. So you find this problem to be happening. Lots of gynecologists are not much sensitive to this problem. They remove the uterus and then they do not bother about sensitizing the women. And so post hysterectomy also we see a lot of women. They are the caregivers. They are the one who take care of the home, and we need to see to it that women at very early age in the community needs to be sensitized as to the problems they can face as far as the bone and joint health is concerned in and around their perimenopausal stage. Next slide. So in the next slide, you will feel that even the men are also not spared, So they are also having high chances that they would get osteoporotic. However, it comes at a later stage, and compared to women, they have a lower rate of getting affected. But if you see a 60 or a 65-year-old male falling would have high fracture rate of their hip, spinal fractures, and the wrist fractures too. Next slide. So you can go a little fast to the other slides, please. Yeah. So this is very silent. That is what I want to say. And this is where we need to make noise. And it is the orthopedic surgeons who can now sensitize. First, we need to get sensitized. And then we need to, for every patient that comes to us, we start talking to them about bone health and about the chances that they would get osteoporosis. In fact, we have to see to it that if there is a possibility of screening with DEXA, without DEXA, and can we find out what is their bone health, and can we do some form of management, lifestyle management, so as to enable them to stop whatever depletion of the bone that they are getting at that stage. Next slide. These are few statistics. If you see by 2050, what is going to happen across the world, it is just fixed for a hip fracture, which is a fragility fracture pertaining to osteoporosis, where you can see it's almost going to rise. More probably, if you see, the rise is in Asia. So for somewhere in 90s where it was 600, and now if you see approximately it's around 900, and while you can see by 2050 you were going to have 3250. It is the rate of hip fractures that you are going to get, estimated hip fractures. Next slide. Next slide. This is, as you rightly say, in the younger patients, our mechanism of fall is much different, while in the older patients, the fall is usually we fall on our hip. And if we have a poor bone quality, we would definitely be suffering from the hip fracture. Apart from that, if we try to fall on our hand, we get a wrist fracture, because even the quality of the bone in the lower end radius is also very poor. So these are the three sites which are very common. It is the vertebral column, it is the proximal end of the femur, as well as the lower end of the radius, which commonly gets affected. Next slide. This is where we are, the vertebral fractures, which are again a common osteoporotic fracture, and anything abnormal activity. And if you have an osteoporotic spine, even if you're pushing anything heavy, the chances as much as, in getting a vertebral compression fracture is very high. 25 to 30% of vertebral fractures seen on X-ray, we are able to diagnose it clinically. Next slide. This is something which we do on a DEXA, where when we do a spine, and you are able to give a trabecular bone score. But as most of us, when we do a DEXA scan, we are usually getting the T scores and the Z scores, and on that basis, we are able to work up. So anything which is less than 1.5, minus 1.5, we are in an osteopenic zone, and between 1.15 to 2.5 to 3 is all osteoporotic. Next slide. So DEXA scan is important. However, apart from that, there are multiple risk factors. Since we are going to FRAX, it is very important that we need to understand what are the other factors which enable us to calculate FRAX, because we'll get to know how in 2008 WHO introduced the FRAX score, wherein the history of prior fractures, our family history of having hip fractures, smoking, alcoholism, steroid, rheumatoid arthritis, and an age were put into an algorithm for us to calculate FRAX score. Next slide. So this is what it is. You see it's a WHO fracture risk assessment tool, and it is an idea for us to calculate the probability in next 10 years for us to sustain a fracture. And if you see, these are the external factors which are put into an algorithm. You can put them and you would be able to calculate. The whole idea of knowing about FRAX was to prevent unnecessarily treatment to the patients, especially women who do not require treatment. And we should be able to manage them, not giving them medical treatment, but just the lifestyle management treatment. And predominantly, the tool was focused on these three conditions: postmenopausal women, men at around 50 and above, osteopenic class, not the osteoporotic labeled more than 1.5, and people who have not taken any previous medicine for treating themselves for osteoporosis. That is where, you know, the FRAX tool plays its role and is important, where you can use to manage through FRAX. Next slide. So these are a few gradients which are associated with the clinical risk fracture, and these are the FRAX scores. If you see, we have different with BMD. Without the BMD, you have a hip fracture and the major fractures together, hip fracture and multiple fractures. To be easily understanding, if you have a score of around -3, 3 equivalent to 3 or above for a hip fracture is significant, and to have a major score of equivalent to 20 or more than that is very significant for major fractures, multiple fractures. So that is where, you know, you calculate this as a FRAX score. It has its own limitations. Can we go to further slides to show you some limitations about this? This is on basis of certain history. You can do the calculations, you will get a rough idea. However, DEXA scan is where it gives you a good idea about, so you have a T-score of -2.1. However, if you put up an algorithm and the history saying about the previous fractures, rheumatoid arthritis, about the parental history, and then you would come to a score, and the last one where you have, where it's all yes, you will find that the major percentage is 21 and the hip is 3.6, where this gives a significant FRAX score. The other scores are not significant. Next slide. So there are advantages of having FRAX. As I rightly before mentioned to you, we do not want to over-treat the patients. We can monitor these patients easily. We can judge the severity. You can document it, and the documentary evidence would be far more important. Along with them, you can go in for a biochemical investigations, go for a periodic DEXA scan too, and all together will give you a good idea about the bone health and the progress of the bone health. Next slide. So these are a few limitations of the FRAX as a tool. If you see that it is very difficult to, if you see the flexibility of this is not much, and it has to be, you know, there are different ethnicities and there are different populations, and where the FRAX scores will vary. So it needs a continuous updating, and it needs to be, it cannot be generalized applied. So it is suitable to be used if you have DEXA. DEXA also is not able to give you the FRAX score because it has its own algorithm, but it's not able to give that. And it is suitable to be used in very limited number of patients that I had mentioned before. Those who are osteopenic, perimenopausal women, men above 50 years of age, and those who have not received any treatment for osteoporosis, biological treatment. Next slide. Now, from the Indians context, if you see as I told you, the problem statement lies in India. There is a huge amount of osteoporosis and osteoporotic fractures. We will be discussing that with Dr. John very shortly. There are more than 100 million postmenopausal women in India, and large number of them reside in the rural areas. So it's not possible for them to go in for an DEXA. However, you need a score where you can take an history and you can able to come out with a score which will enable them to judge as to treat them medically, apart from the pathological investigations that you would do. And therefore, it is important for the orthopedicians as well as the physicians, which are at the primary care physicians or the family care physicians, that even if the DEXA is not available, you can use FRAX as a tool for management of osteoporosis, irrespective of the fact that it has its own limitation. But this class of patients, you can apply FRAX, you can apply the algorithm based on the factors that have been described, and you can come to an idea as to what you should be treating them with the drugs and medicines or not. Next slide. This is something about, again, a way to look at how FRAX can be helpful with or without BMD. But the probability of fracture, once you have, as I rightly before pointed out, that with a HIP score of 3 and above and the majority score of 20 and above, you have to treat them with the medications required to treat osteoporosis. Otherwise, the probability of fracture reduces. It is not much, and hence lifestyle modification, sunlight exposure, dietary management itself is more than enough for those class of patients, at least the postmenopausal or perimenopausal women who are just osteopenic and are expected to be osteopenic, and they have not taken any previous treatment for osteoporosis. Next slide. As I previously mentioned globally as well as in India, the geriatric population is going to grow. Presently, we rightly say that India is a young nation. If you say above 60, India has only 9% of its population which is above 60. However, by 2025, we are expecting around 12 to 15% of population above 60, while by 2030, you can have around 22-23% of population which will be above 60. So that's where the problem statement lies. If the disease is so silent, even it is progressing, we as an orthopedic surgeon are going to face the huge load of fragility fractures, which would be a big socio-economic burden to the society. So we need to work now. Now is the time. Next slide. Friends, that brings an end to this discussion where, my vision is to have a global community with reduction in fragility fractures so that they have a healthy and pain-free mobility throughout their life. And that's a part of longevity. And this is a work which we should do as a purpose towards mankind and towards humankind. To end this presentation where we have given a fair idea, can you close the presentation? And can I be on the screen, please? Yeah. So now I would request Dr. John, after having given this introduction, sir, I would like to know, over large number of years of orthopedic practice and with large number of fragility fractures that you have fixed, what were the challenges that you face while addressing these patients with fragility fractures?
So I'm going to touch into that during the talk, but the biggest problem with osteoporotic fractures or patients with osteoporosis who have fractures is not the healing of the bone, but the hold that their bone or the implants have in their bone. And therefore, the risks of implant loosening or cutout and fractures around the implant go up significantly. So that is the real problem. Their bones will heal if they're managed properly, but you have problems with your implant holding. So you have to plan your fixation in a way that it's going to be able to hold out till the fracture heals in that osteoporotic bone and that population.
So, sir, I would like to know what is your idea when I say that India, even the world, but in India, if you see that if our population is going to be more in the elderly above 60 years of age, and if the problem of osteoporosis is not addressed now by us as an orthopedic surgeon also, don't you think the large number of population above 60 years who will have fragility fractures will create further problems to us as an orthopedic surgeon, because the more they have fragility fractures and the more that we fix, the more we try to treat them, the more chances that they will have the bone failure and the more chances they will have to go in for revision and the recurrent surgeries.
Absolutely. And I think even in, if we look at say in the last 10 to 15 years, I can see a definite increase in the number of these osteoporotic fractures that we are dealing with. On top of that, we have people who've had joint replacements or fixation for a previous fracture who fracture around the prosthesis or implant. And we in India are really still in the beginning of the curve. I mean, if you see the West and see the kind of elderly population they have, this osteoporosis and osteoporotic fractures is reaching a stage of more than an epidemic. It's like, and they are changing their whole concepts of fixing these fractures to try and prevent further fractures taking place. But that involves almost fixing the entire bone from top to bottom. And then you have a different problem because of the bioelasticity of the metal is never the same as that of bone. So it'll be interesting to see what happens. But India, we are still in the beginning of this curve and it's going to go up exponentially over the next few years.
So as you rightly said, that we being an Indian, being an orthopedic surgeon with having an experience, you having an experience of over 4 decades, me being part of the orthopedic fraternity for over 2.5 decades, we need to sensitize our youngsters, our young orthopedic surgeons who would be seeing many patients, and they should be now thinking in terms of adapting to the measures of in terms of awareness and education to every aspect of the community, so that we have a very low, we don't want a steep rise curve, you know, we don't want many patients in the future who turn out to be like more than an epidemic for the fragility fractures. So that is where, you know, I would like to know from you, because this, I have taken it up as a passion and as a purpose that we have to spread. Even we don't depend on endocrinologists as an orthopedic surgeon, though it is not very, the preventive aspect and the optimization of bone and joint health also should be one of our own duties too.
Yeah, absolutely. So when you get a patient with a fragility fracture, your duty does not stop with treating that fracture.
Exactly.
I think it's absolutely important that you educate not just the patient, but everyone else around, that once they have one of these osteoporotic fractures, the risk of them having a second fracture goes up. And then if they have a second, it goes up more. A lot of these hip fractures have significant morbidity and mortality attached.
Yes.
Okay, so very few of them actually get back to their pre-injury status after a bad trochanteric fracture or a hip fracture. They always have some loss of function, and a lot of community ambulators end up as home ambulators, and home ambulators end up as wheelchair patients. And so I think it's the cost to the medical sort of services is enormous, and it keeps rising. I mean, if you look at the US, these have really skyrocketed to almost astronomical levels, and I think India is going to follow soon, irrespective of what we do. But we can certainly try to bring down the enormity of this rise.
So the difference between the healthcare system in US and India is vast. Most of the patients in India come from the rural part. They pay by their own pockets. We don't have insurance companies. If you see, if there's going to be an epidemic, that means these patients will have to pay a huge amount of money from their own pocket, which is going to be a big social and economic burden on the society itself, right?
Absolutely.
So,
yeah.
And that is where, you know, we need to be more sensitive about this aspect of osteoporosis as a disease, and the whole idea of sensitizing our own young generation of orthopedic surgeons that please apart from the repair, about the resurfacing, fixations and rehabilitations, let us start talking a little bit, say even 10% of an effort of our daytime we can make in terms of educating community towards prevention and education of osteoporosis. So we would like to hear your presentation about the challenging cases too.
Great. Okay. So yeah, absolutely. I totally agree that I think that's really of great importance that we do that and also sensitize people to it. So I'm going to share my screen. Hopefully this works. Yeah, looks like it is. Okay. So I'm going to talk about some of the challenges we face in the management of these fractures. And I'll start with a case which is a 68-year-old lady who first presented with this fracture to another surgeon. Okay, so you can see how things progress. Although, yes, it wasn't managed properly in the first instance. Okay, so that was what was done. And the surgeon, when he came back from theater, did the post-op X-ray. He actually noticed this probably just during or after surgery because this was the X-ray he got. And so he took this patient back the next day and he put in these wires and an additional plate. Okay, now over a period of time, you can see that this is failing too. And this wire has migrated now to the shoulder joint, which has caused problems. And then it got infected. One wire backed out. He took that out. Eventually, he had to debride everything and take out all the implants. And that's what she ended up with. And then she had further revision surgeries. So you can already imagine that she's already had 6 or 7 surgeries by this time. And then she presented to one of my colleagues in our hospital in this condition. And I think he posted her for surgery with the plan of fixation and bone grafting, because at that time, the infection looked quiescent. Although when he went in, he found frank infection, or he found some pus. And you can see even on this X-ray that this part of the bone is sequestrated. So you had this very unstable situation with poor quality bone, a shoulder that was now stiff, and a low fracture with a stiffish elbow, which meant a huge amount of stress around this region. So we did the thorough debridement, but we felt that stability was essential to us dealing with the infection as well. So we planned on a masculate technique. We debrided it adequately. We use the cement spacer, as you can see in this area. And then we use these 2 plates to stabilize the fracture. And the idea was that within 4 to 6 weeks, we'd go back in, take out the cement, put in bone graft, and maybe add supplemental fixation if necessary. Unfortunately, this lady didn't come back till about 3 months. Okay, this was the plan at 4 to 6 weeks, but she didn't come back till 3 months. And that was what had happened. She had broken at the end of these plates. So right at almost the joint line. Okay, so here was a situation where you had now very little bone here. You had a stiff shoulder. You had an elbow that was already stiff. And we had to try and, luckily the infection was controlled. So that was what it looked like inside. We had ended up having to remove some more bone. We used a fibula. And we used these 2 plates to fix this in a position. So the idea was to fuse the joint in and take the right hand to be like the left hand and do it in about 35, 40 degrees of flexion. Maybe we could have done some more flexion. But then the next thing that happened was, by the time she came for a suture removal, this is what had happened. Okay, so now you just see the kind of sequence of events which gets worse and worse. And then finally, I decided that now it's time to just not be too heroic, because there was some amount of, it wasn't frankly mobile at this stage. So what we did was we just gave her a slab in that position, a plaster slab. And over a period of time, this went on to heal. And so she had this stiff elbow, but at least she could use this arm. Her hand function was okay. Unfortunately, this lady has passed away, so we don't have further follow-ups on her. But at least she went back home. She was able to get back to some kind of function by the time. But you can see the sequence of events and the kind of problems that one can face if things are not done right in the first time. So we, as was mentioned earlier, we do have increasing longevity of people worldwide, and therefore we are going to have an increase in osteoporosis and therefore an increase in osteoporotic fractures. And this is going to be a huge burden on resources and, as I showed, major challenges to the fixation. Okay, and this is what we are talking about in the US, that in 2013, the cost of treating these hip fractures was around $20 billion, and this is expected to double by 2050. And about 10%, so even in the US, about 10% of these fractures end up in fixation failures. And even when it is successful, an average of 1 to 2 units of transfusion to these patients and 4 to 5 days of admissions. That is when they do rapid discharges. Okay, and I'm not going to go too much into the pathology of osteoporosis, just to tell you that it affects both the cancellous bone and the cortical bone. The cortex becomes like a thin shell, which can crack easily, like you can see in this case. And the cancellous bone, you have less and thinner trabeculae with fewer and often broken interconnections. So if this is normal bone, this is what an osteoporotic bone looks like. So what this then leads to is a tenfold reduction in the pull-out strength of screws as you go from the age of 50 to 80. So over a period of time, your pull-out strength of implants, screws, etc., goes down by tenfold. Okay, so what the problem is not micro movement or callus response, it is stability under load and the compromisation of your implant fixation. So impaired biology is not an issue, but implant fixation is definitely the issue. And operative complications such as failure of fixation, secondary loss of reduction, and iatrogenic fractures are not uncommon. And you have the peri-implant fractures. So you have all these sort of things with pull out of screws, loss of fixation, and then if they're not managed adequately, just lead on to more and more problems. As I mentioned, you have these periprosthetic fractures with these elderly patients who had a hip fracture and then has had it treated, and that gets worse. You have the knee replacement or the hip replacement patients who end up with periprosthetic fractures. And we had different strategies to deal with this. Before we had the lock plates, we used different techniques like thick nails, use of cement to augment your screws. Also in this case, where a proximal femur fracture with very osteoporotic head, so you could use cement with your DHS. You need to valgasize to improve the biomechanics and cement to increase the hold of the implant. And even in these situations, you can get them to heal. And you can augment your fixation with external fixators if necessary, although this in the elderly is difficult, but in very osteoporotic bones, which we also sometimes find in the young, when the fixations have failed with a period of time with disuse, you can use these augmentations. You have to be careful how you deal with these bones, because using clamps which you'd use in normal bone can actually just crush through bones and lead to increasing problems. I think the advent of the lock screws or the lock plates has definitely improved our ability to get good fixation in these osteoporotic bones, but it doesn't mean that we've solved all the problems. But I can show you examples where this patient had had 3 previous surgeries, failed, and then we could use these locking plates with a double plate fixation and bone graft to get her to heal her fracture, and with a good functional result at the end of 21 months. Here is a lady with a 6-year-old injury of the proximal humerus, which was managed conservatively. And now you can see the quality of bone from disuse. And here you can augment it with a intramedullary fibula graft to increase your hold and then get on to healing of this fracture with a reasonable functional result. Another 80-year-old lady, 1 month old injury, which was managed conservatively, and this is never going to heal. And here you have to decide between a primary replacement and trying to fix. And sometimes maybe a replacement is a better idea with some, but you need a complex prosthesis for it. So here we decided to go ahead and use a intramedullary fibula to augment our fixation, used a locking plate with polyaxial locking screws to give us a good hold. And you can see over a period of time, this fracture's gone on to heal. Unfortunately, I don't have a longer follow-up because she lives somewhere outside Delhi and hasn't come back for many years, especially with the pandemic. So that was at 3 months. Okay, then you also have some improvements in some of the implants that we have. So where you have these periprosthetic fractures or peri-implant fractures, which reduce your ability to put in screws into this region, you have these attachment plates, the so-called spider plates or attachment plates, which allow you to put in extra screws in different directions. So this was a lady we'd operated on many years earlier with a trochanteric fracture, and we'd put in this nail, and she fell again, and she came back more recently, about 5 years ago, with this second fracture. So here you had a nail which had been there for many years. If you try to take it out, especially with the broken bone, it was going to be a disaster. So what we decided was to bypass the nail, put in as many screws on each side of the nail proximally as possible, and use a long distal femur plate. So you can see you've got the long distal femur plate, we've got screws around the nail where possible, and we've got this spider plate with attachments where we could put in 2 or 3 extra screws into that area. Plus we have cerclage for the spiral fracture. So it's a combination of things that you need to get these fractures to heal satisfactorily. And you can see how this has gone on to heal well, and we were able to salvage the situation, again, in a somewhat difficult situation. As I mentioned, you also have newer implants which allow you to inject special cement through it, even after you've put in your fixation. So you feel that maybe the hold is not so good, you can inject in cement. This nail has fenestrations in the screw which allows cement to go through. And this is there with the DHS as well today. And again, you have to plan your fixations for these periprosthetic fractures so that you get good stability to allow motion. Because with these elderly patients, if you keep them in bed, they become even more osteoporotic, and that would get worse. So you have to be able to give good stable fixation so that they can start mobilizing early. We also have this problem of atypical fractures where you've treated patients for osteoporosis with bisphosphonates. And you've done this for a long time. So early on, people would have had it for 6 years, 7 years, and then they would come back with complications. And the atypical femoral fracture was the classical one, which could be missed easily. They have some prodromal symptoms, which they may or may not have. You see the X-ray, you can't see anything, but you have to watch out for these subtle signs. There's this black line or the slight callus formation near the lateral cortex, and you need to anticipate them before it happens. An MRI can help you in that, and you need to provisionally or almost prophylactically fix these. So I'll end this talk with another kind of disaster scenario. Here's a 68-year-old lady with this fracture. A relatively difficult fracture, but not one which you should be able to do adequately. After the surgeon, and this is not a unqualified surgeon, he was a qualified surgeon. He had the degrees he needed, etc. And he spent 5 hours trying to get this and eventually ended up with this kind of fixation. And 3 weeks later, this is what happened. So at this stage, when she came to us, we got a CT scan, and you can see how this was just to really show it in light. It was obvious that we needed to do something. But you can see how this nail had never even entered this part of the bone or never had any hold in that part of the bone. Okay. So this is what osteoporosis can do to you. So we went in, there was also some low-grade infection. We put in this long plate, we put in some antibiotic cement, we tension wired the trochanteric area to give it some additional hold. And she came back to us. This was the post-op lateral X-ray to make sure everything looked okay. And she came back at about 6 weeks doing quite well. She was walking with a walker. And that was the stage we advised her to have a bone graft here. But she kind of did not want further surgery and was doing well. She was managing okay because the fracture somehow seemed to heal around this because it was a good stable fixation. But she came back last year in November. That was about 2.5 years after the original treatment. And now she had this fracture at the end of the plate. Okay, and this fracture wasn't just here. It was extending very close to the knee joint. As you can see on the CT, the fracture is going right there. So now you have a very small area. You have this long oblique thing. So again, an implant higher up, which you don't want to take out. And so we had to work out how to do this. So we took out all the screws in between. We put in this distal femur nail with additional cerclage wire, and then the locking of the nail here. So we bypassed this fracture. We got an additional screw into this distal fragment through the last hole of the plate so that that was not unstable. And this is what she looked like. She was doing okay. One part of it, I forgot that when she came to us after this second fracture, she came a bit late, about 2 weeks after this fracture. And by that time, her general condition was precarious. We had to admit her in ICU. The anesthetists were not willing to take her up for surgery. So we put her on proximal tibial skeletal traction just for that time period. And she interestingly improved with over a week or so. And then her general condition became such that we were able to operate on her. So we did this. And then what happens? You can see here through this area of the tibial pin traction, which was a little anterior, she's gone and cracked her tibia. Okay, proximal tibia. So we just splinted it because this was an kind of displaced fracture, just a crack, incomplete fracture. And she went on to do okay. And a recent review, she came back recently and things were healing up, but she was very reluctant to walk because of all that she had been through. So I think this just shows you that what the problems really are. I think osteoporosis does not impair fracture healing, but it does affect both cortical and trabecular bone in different ways, which makes fixation difficult. And you really need to plan your fixation very carefully and use adequate fixation techniques with suitable implants to deal with the problem. I think the locking implants has helped. We have newer generation nails as well with multi-directional locking and locking interlocking bolts, which have helped. And combinations of plate and nails are being used a lot more. And remember that refracture rates are as high as 12%. So you need to watch out for all that. And most importantly, try and get things right the first time, because these fractures create problems. And when they fail the first time, very often you end up having multiple problems along the way. So I think with that, I'm going to close this the talk and stop sharing my screen, and then we can get on to some discussions on the problems that we face with these fractures.
So those were very interesting cases that you had shown, and I am sure that the large number of orthopedic surgeons who would be seeing these cases would surely be getting some learning out of it. My question to you, sir, is for the benefit of all, that when you see such patients who come to you with such fragility and you do a good fixation, do you think or anticipate that there are chances of refracture, maybe not in terms of non-union, but maybe at places which is, say, at the end of the stem or at the end of the plate, there? And do you think what do you do as far as lifestyle management is concerned, and what do you do as far as the biological management is concerned?
Yeah, so I think you have to do all, it has to be a multi-pronged attack. You need to educate them on the risks that they face of refractures, and the elderly tend to fall. So they have to do modification of their house environment. Very often there are carpets and rugs lying around which they can easily trip over. In the bathrooms, they need to have handles and things like that put which they can support themselves with. So that's one side of it, is the how you alter the home
Lifestyle
environment to prevent falls. You have to warn them that. So one of the, very often the problem comes when they suddenly get up in the middle of the night to go to the bathroom. So I think the children or their caregivers have to be told that don't let them do that totally unattended. They often don't even switch on the lights when they do that. So that's another reason. Osteoporotic medication is important. And I think this is where, and exercise. So walking is probably one of the most useful exercises to prevent osteoporosis, especially for these elderly who can't do much else, because it's still a weight-bearing impact kind of exercise. There are some other things which you can do. So it has to be a multi-pronged attack. Their medication has to be looked after. When you're very often they're on sedatives or some other drugs which make them sleepy or disoriented, and that leads to troubles. They may have neurological problems, subtle neurological problems, which need to be dealt with. So I think it has to be really a multi-specialty, multi-pronged attack to deal with these.
So coming to vitamin D, so how often do you get calcium levels, B12, vitamin D levels, as well as other investigations done prior to the surgery? And then do you do anything to, or do you give any medicines to correct all those parameters?
Yeah, so I think we don't, once they're fractured, then you need to get them operated soon, okay? So the idea is that within, you can actually improve their prognosis if you can get them operated within 24 to 48 hours so that they're able to get up. Obviously, you need to take care of things like uncontrolled diabetes or things like electrolyte imbalance, etc. Even blood thinners today are not a contraindication for surgery, because through the fracture, they'll be bleeding. So what they will bleed through your small incisions, because a lot of these things are done through minimally invasive approaches, is less than what they would be bleeding through the fracture. So once you've stabilized it, you probably are going to reduce the bleeding. But obviously, if they're on oral anticoagulants, that you need to get the INR down to a reasonable level, especially if it's way high. But you can't deal with osteoporosis before you treat the fracture. That's something that needs to happen in the postoperative treatment protocol. Yeah. So yes,
so for the purpose of the audience, in your practice, what is the protocol that you follow?
So all of them get vitamin D, all of them get calcium. The ones which have really severe osteoporosis, we actually get the endocrinologist to also have a look at them while they're there. Otherwise, we would give them prophylactically. Usually it's bisphosphonates for the majority, but if it's very severe, then we might go on straight to teriparatide. And I've not used denosumab so much, but that's the next drug that we would be using soon.
Yeah. And with your experience of this osteoporotic regime that you follow, are you convinced that their bone quality to some extent has improved, which has prevented them to get refracture? That's question number one. Or do you think this has also helped them in any form of bony union, a good bony union?
Yeah, so I don't think the medication helps with union. I think teriparatide probably helps hold with the implant hold, because if the osteoporosis, the implant hold is going to, there's not much evidence, although there's some new research work going on that it may help healing in animal models, etc. But the main treatment that they are licensed for in the US is for osteoporosis and not fracture healing. Okay, so we do give calcium, vitamin D, make sure the vitamin D levels are adequate. We make sure that we get them mobilized early. That's important because weight bearing again improves healing and also improves the osteoporosis. So I think these are important. And along with it, you need to treat the osteoporosis. So usually it's bisphosphonates because bisphosphonates, oral bisphosphonates will not interfere with fracture healing because by the time they get into bone, it's 4 or 5 months down the line. So people should not have worries about bisphosphonates affecting the healing of the fracture.
Okay, thank you so much, sir.
Yeah.
We are concluding this program. We are nearing 9. Can I have Dr. Hirsch to give the concluding remarks?
Sir, yes, I'm there, but the last words which Dr. Mukhopadhyay spoke, regarding the use of oral bisphosphonates. Sir, I have a question. We progressively see the world more moving towards, whether because of compliance or tolerability, injectable bisphosphonates and once a year kind of formulations. And also there has been a sort of a paradigm shift, if I can use that word, in the treatment of osteoporosis, that people are more now looking at anti-resorptives and since injectable bisphosphonates, denosumab, or the anabolic agents.
So like I said, I don't want to go into the details of medical treatment of osteoporosis.
No, it's just thought here.
Yeah, it's going to happen. Everything changes over time. Okay. So as you get denosumab available, but they're expensive. You also have to think about that. Okay.
Hugely expensive.
Mab, teriparatide, all these are expensive drugs compared to bisphosphonates, oral bisphosphonates. Even the injectables ones are quite expensive. So you have to tailor it according to that. Injectable bisphosphonates also have they need to be given IV under medical sort of.
Yes.
You can't just ask them to have it at home.
Just can't go about injecting. Yes.
Yeah, so I think so. Those are all things which are going to happen. But like I said, that is more a medical side, which I told you before that I don't want to really get into details of pure medical treatment of these. Important that they have it. That's all I can say.
Yeah. One question which I have been since our pre-talk discussion, and especially what Dr. Jain stated last DO meeting, where it has emerged that especially when we are using such anti-resorptives and anabolic agents, there is a need to rapidly build up the vitamin D levels. There's most of the patients will have inadequacy there, in whether deficiency or insufficiency, they will be inadequate. Now, do you see any such thing when we are doing the surgical corrections and those things prior to that?
So, I mean, we give them vitamin D almost routinely. We do check their levels, but we don't stop treatment because of that. In these acute fractures in the elderly, you need to treat the fracture and then get on with the treatment. Okay.
Okay. Dr. Jain, sir, your thoughts?
Yeah. So in the OPD settings, yes, most of the patients that come to us, looking at the age group, looking at the patients that is coming to you with the complaints and the symptoms that they have, or the diagnosis that we make, we definitely focus on to the expected osteoporosis in a patient. Even on an X-ray, you can have a fair idea. Calcium levels, B12, vitamin D3 levels definitely are investigated, and as you rightly said, we would love to augment, because Dr. Mukhopadhyay also said in his very beginning remarks that you get large number of population who are low on vitamin D. Large number of patients come to you with 8, 10, 15 vitamin D levels, while getting these patients to at least 40, 50 and to optimize them to at around 80, 100 would be the good idea, because that is where we would be working on to the management, which is not what we want to do within the scope of this particular discussion. But yes, optimizing the patient with its vitamin D levels is important. And you have your product which enables us to do that. And I think we have Dr. John who wants to join our meeting.
Yeah, it's past 9 o'clock, unfortunately. So
yeah.
I have to So thank you very
Dr.
much.
Harsh, we would request you to give concluding remarks
Yeah,
and maybe
please,
Dr.
Yes, thank you so much, sir. What I gather from it, yes, FRAX is relevant in the Indian context, especially when we look at the socioeconomic status and accessibility of Deksel, especially in the interiors. Yes, there has been a shift. But one question I'm still very itchy to ask, sir, Dr. John, if you can give me just 30 seconds. My question pertains to recent phenomena where we see more literature emerging and coming, which implicates hyperhomocysteemia in osteoporosis. Any thoughts on that?
You're again drawing me into medical management. Yes,
I can't help it, sir.
I'm afraid I'm not going to get into that at all. Okay, so you can discuss it with your physicians.
Okay, Dr. Jain, one last word.
Quick word is we have to manage osteoporosis as early as possible. We as an orthopedic surgeons, if we suspect that the patient is in the age group, if the patient is in the perimenopausal stage, the patient has undergone a hysterectomy, the patient is postmenopausal or a men, or apart from that, they're alcoholic, they are diabetic, they have lifestyle diseases, we have to treat them if we find them to be either osteopenic or osteoporotic, for sure.
Thank you so much, sir, for sharing your thoughts, your experience. Dr. Mukhopadhyay, we are very grateful. Excellent presentation and cases. And to you also, Dr. Jain. And sir, we'll be bothering you both time and again. This was a lovely presentation, one of the finest we had on our show. Thank you so very much for taking time out. Thanks a lot.
Thank you so much. Thank you. Thank you so much. So the recording has stopped, OrthoTV?
Are we still recording?
The recording has stopped.
Thank you.
Okay. So